So we've now got Sarah Nate to talk to us about prehabilitation. Unfortunately, she couldn't be with us today. She very kindly stepped in at the last minute as a speaker because somebody else dropped out. So thank you very much for stepping in at the last minute. Sadly, she couldn't be here in person, so she's going to do her talk over Teams. Thank you.
Thank you very much. So as Amy said, my name is Sarah Neat. I'm the Macmillan physiotherapist from the Great Western Hospital and the joint team lead for our personalised care team. And my talk today is on cancer prehabilitation. I hope you can all hear me okay. That's right, there we go. So first of all, when we talk about prehabilitation, we've got to talk about the 3 pillars. So this is exercise, nutrition and psychology. And the idea of prehabilitation is basically preparing someone's mental and physical health before they then go on to start their cancer treatment. Prehabilitation has been available in various trusts and areas within the NHS for a while now, but albeit it's quite sparse and basically different between different areas. So in 2017, Macmillan did an evidence and insight review where they looked at what was going on in the NHS, what offering of both prehab and rehab there was, but also to look at how beneficial it could be as part of a patient's pathway. And the key finding really is it showed there was a lack of consistency. So the outcome measures that were used or the way we were delivering prehab between different trusts was very different. Some people were doing group sessions, some one-to-one, some telephone or even just online content, which made it very hard to measure the success of prehab. Off the back of their review, they then created some guidelines for both prehabilitation and rehabilitation, and then started to pump prime projects to try and make it more nationalised so that most acute trusts could have some deliverable with regards to prehab and or rehab. And generally, when we look at the national research, we know that prehabilitation can improve personal empowerment, it improves physical and psychological resilience, quality of life, creates a sense of control and purpose, creates a positive health behaviour change and improves their long-term health status. And the behaviour change, I think, is a really key thing for prehabilitation, which I'll touch on in our own project. So the other thing that's important to note that they mentioned in their evidence and insight review is that just offering prehab or just offering rehab, so the post-treatment aspect of rehabilitation alone is not enough to improve someone's baseline health status. So they go in, they feel generally okay, they then start treatment, their health status drops. If we just offer prehab, it will build it up initially, but it won't pick back up to that baseline, and the same with rehabilitation. So it's important we offer both types of therapy. A really useful systematic review done by Campbell et al. Looked at not specifically prehab or rehab, but the benefits for exercise alone for cancer patients. And their review was very, very thorough, so really worth looking at if you've ever got free time. But it shows that exercise can help with the prevention of 7 common cancers. It might be small on your screen, so I'll just read it out, but it talks about helping prevent bladder, breast, colon, endometrial, esophageal, kidney and stomach cancers, and it also can help improve the survival of breast, colon and prostate cancers. Now, exercise itself has been used as a treatment for or as an adjunct, an extra type of therapy input for cancer patients for a long time, but the research specifically for gynae is not as thorough as the other cancer sites. What this review did also look at is where there is a strong evidence for reducing those long-term side effects of cancer. And where there is strong evidence is that it can help with cancer-related fatigue, which I think is really important because about 90% of our patients will have some degree of cancer-related fatigue. It improves overall quality of life, their cardiovascular function, and we know it helps with anxiety, depression. And an interesting one for myself, because I'm a physio, is lymphedema, that the strength and resistance elements, so weights or resistance bands, can help improve the management of lymphedema, which I think is quite important when we've got lots of patients who struggle with lymphedema symptoms and that self-management aspect of it. The review then goes on to look at the moderate and the low level of evidence, which I haven't added in my slides because of time, but it is worth looking into. It talks about bone health, weight management, where there is moderate links to how exercise can help provide a benefit. When we look specifically at gynecological research, as I said, it's a little bit behind the post compared to, for example, breast, lung, or colorectal. But one of the key things, and this isn't just for gynae, it's across the board, is there isn't really a standardised national framework other than what Millen provides. There isn't anything on the NICE guidelines for gynae and prehab and rehab. It mentions physio lightly, but more that to refer into if there is a side effect or a symptom that needs managing. The other key thing when we look at the research for the gynae prehab is that there is a lack of consistency on what kind of prehab is offered and the outcome measures that are used. But what we do know is there is statistically significant improvement in the 6-minute walk test, which is a cardiovascular test, and when we measure the depression and anxiety scales. And again, linking back to that national research, it improves quality of life, strength and fitness. And an interesting one is a few articles cited its benefit in helping with weight loss management and obviously treatment outcomes. There's some research out there talking about post-op complications, but there's not enough to really show that significance. When we look at offering prehabilitation and rehabilitation within our service at Great Western Hospital, we decided to follow the NHS England's comprehensive personalised care model. And this basically is a very simple model that just helps us dictate the level of service we provide for our patients. And what it says is about 5% of patients under a specific condition will need that bespoke one-to-one, more complex support. 30% will need that more targeted, so specialist knowledge and information for self-management. And then everybody can have access to online materials, things like our Macmillan guides and leaflets. We adopted this model into our practice to set up a more robust service. So our team, we are called the Personalised Care Team, and we are a mix of healthcare professionals. So we've got clinical nurse specialists, myself a physio, an occupational therapist, and admin and rehabilitation assistant support. And we also work closely with psychology and dietitian because I mentioned they are part of the 3 pillars of prehabilitation. We can't have them directly in our team, but we work closely with them and we've got a screening pathway. Now, our team don't just do prehab, we also do health and wellbeing and rehab. And I just wanted to say, I think it works really well having that all in one team because we can be a bit more seamless. If a patient mentions an issue, we can then get them the right support from the right person at the right time. So it works quite well to have that multidisciplinary team approach. Now, when we look at that specialist support that we offer, within our team, we offer one-to-one clinics for physio and OT. So specifically for prehab, we haven't got clear pathways for all cancer sites yet, because again, the NICE guidelines and what we define as a high-risk patient isn't very specific yet. But for breast cancer, NICE guidelines now have a clear criteria of who is high risk. We see them all one-on-one in clinic, and then stem cell transplants, we see all of those patients one-on-one in clinic. Over time, my goal is to create a pathway on each cancer site and defining with the team who is a high-risk patient so that we can make sure we are acting fast for those complex patients. And it is important when we're looking at specialists, that dietetic and psychological support. Now, our main service offering at Great Western Hospital is our targeted group programme, which initially started about almost 2 years ago now, but initially just for lung cancer off of the back of various reasons, which I haven't got time to go into much detail today, but our programme comprises of 6 sessions of group-based exercise and education twice a week. So patients get about 45 minutes of exercise that is strength, aerobic, pelvic floor, abdominal stability and breathing. And then we do about 15 minutes of education, and this is on diet and nutrition, emotional resilience, stop smoking, weight loss. We always tailor our education to who is in the group at that moment, and we've built our education in collaboration with our psychologists, our dietitians and our social services. Now, the group currently is just for lung, gynae and colorectal, and the main reason is our capacity to do so and which patients are having surgery in-house in our acute trust. Hopefully, over time, we've just recruited more staff, so our plan is to slowly add other cancer sites. And this service is led by a physiotherapist and a rehabilitation assistant who's got knowledge and training in cancer rehab. And as I said, we've got a pathway. So we use a screening tool at diagnosis for both psychology and dietitian, and anyone that is flagged immediately gets sent to those teams as a more preventative and a proactive approach. The universal side, I thought I would touch in just lightly, but we've took on the approach of having an online platform. So we have online videos that can go out to all cancer patients on various prehab and rehab topics. And we've recently been awarded some funding to do something specifically for breast, to actually have a breast group that's online, that's targeted. But as part of that funding, we are going to look to expand some of the education topics so that patients can basically be emailed some nice unique information towards their cancer site and how to improve their own health status themselves. And then a key thing is that signposting to local gyms. So we've worked with our local leisure centres and the social services within our area. We all know most of our cancer patients live in a very large geographical postcode. So it's important that if they can't come to see us, we've got somewhere we can send them. So we've worked with our local gyms to get them trained up in cancer rehab. They've attended specific courses. So even if they live an hour from Swindon, we can still send them somewhere for support if they wish. And then finally, we are currently working within our commissioning group. So we're under BSW to make sure that what we offer in Swindon is as similar as it can be to Bath and Salisbury, our other acute trusts. And we're trying to streamline our platform so that we can send patients to other localities if needed. So to go into more detail, because the main service we offer is our targeted group. As I said, it started off initially for lung, and it was off the success of our data that we were unable to expand out to gynae and colorectal. Now, when I made this PowerPoint, it was quite a few weeks ago now, so the data is already a little bit out of date. But since July 2024, we've had 67 patients. It's actually now over 100 referred into our programme. And at the time of making the PowerPoint, 18 of them were gynae patients awaiting for surgery. Now, 4 of those patients that came to our prehab, they were unsuitable, so they needed specialist support, and that was because they were high risk. So 2 of them had had strokes. One of them was on home oxygen and one of them was housebound. So when I set up the service, it was important that I worked with the other services available to patients. So I worked with the community teams, and we have a really strong network. So whenever someone is a high risk, I contact that physio directly, and they normally see them within no more than 2 weeks to then start that process, because often we do get patients that have other comorbidities, or they were admitted, had a stroke, and they found, for example, a cancer. So we still need to treat the symptoms, so that patient will need that stroke specific support as well as preparing them for whatever treatment they're about to have for cancer. Now, out of the gynae patients, so this isn't counting the other cancer sites, we've had 9 patients come to our class and complete 6 patients come to the class and complete all their sessions. Again, this is out of date. We've actually had lots more than that already, but it is what it is. Out of those patients, every single one of them that has completed prehab with us has enrolled in the follow-up class. So I said about that connection with the gym. We've got a follow-up class that we send them to, because when we look at the research, if patients do increase their exercise tolerance, if they completely stopped tomorrow, normally within about 6 months, they will revert back to their previous baseline, which we don't want. We want that health lifestyle change. So we developed a streamlined pathway so that once they complete with us, they then within 2 weeks will start at the new class at the local leisure centre. And it just helps hopefully improve that engagement and that empowerment to continue that health journey. Now, the outcome measures we currently use at Swindon is the 6-minute walk test, which is a cardiovascular test, 1-minute sit-to-stand test, which again is cardiovascular, and then we do the FACIT fatigue, and then 2 different quality of life questionnaires. One of them is specific to cancer, the other one is used with all other long-term health conditions, which is useful to measure to see how we're comparing to other prehab and rehab services for the other long-term conditions. And so far we're seeing an improvement across the board. But again, this data is very early, so it's really tricky. We can't generalize, it's not representative of the population yet, but hopefully in a year's time, I'll be able to give a more thorough report. We always check for needs. So the reason we do the quality of life questionnaire in particular is it really helps pinpoint if there's specific needs that patient has. So out of the patients that have come to prehab, 4 of them have had one-to-one dietetic support, and 1 of them has specialist psychological support because her treatment was quite high risk with regards to mortality and, just poor outcomes. Now, it's really, really important if any service is looking at setting up rehabilitation to have that multi-professional approach. You need to have some kind of dietetic pathway or a dietitian involved. If we could in our team, we would, but at the moment we don't have the funding. Psychology, when we look at the research for prehab, it's not as strong a need for rehabilitation, but it is definitely beneficial. But it is a need for post-treatment, so rehabilitation. So once we can start that conversation early, our hope is that patients will have a more self-management approach and then can flag earlier if they're struggling and if they need that more specialist support. Again, that's signposting, so making sure you've got good networks with the gym. And something actually what we learned from our prehab program is the importance of the loved ones, the family members. So when we first started out with lung, we started to get quite a little horde of partners waiting outside whilst their patients were having prehab. And what we started as a trial is to ask a nurse to come along once a month and to basically chat with them. And this has slowly transformed, and we now run a carers cafe with our local carers charity, because we realise actually there's a real need for the partners and loved ones. They've often got their own concerns and worries, but they don't necessarily raise it with their loved ones, with the patient, but also with their healthcare professionals. So actually, we've almost set up a completely new support system off the back of running our rehabilitation. And then again, that pathway, so if someone does need one-to-one support and they struggle to get out of the house, making sure that community team is proactive and rather than reactive. Our community team in Swindon, unfortunately, has a very, very long waiting list. So we had to work quite hard with them to get them to see these patients sooner rather than having them sit on a list for months, deteriorating. And then obviously an important factor is getting the nurse specialists involved, because we can flag if we're noticing any change in symptoms, and the consultants, because at the end of the day, we need the patients referred as soon as possible from diagnosis. The way we work in Great Western Hospital is when a patient gets diagnosed, the consultant discusses rehabilitation, and then that referral letter that goes on for further treatment gets sent to our team, and we then call them within a few days. So we very much call them within a week or 2, no more than 2 from their diagnosis. So we catch them at quite a scary time, but I will say it's a really teachable moment for those patients, and we get really good engagement by catching them early because they are in a moment of wanting to make change and trying to improve their health. Now, another thing we looked at when we set up Cancer Prehab is looking into whether it had any role in cancer targets. So we got our Somerset Cancer Registered Data Team and our MDT coordinators to have a look at the dataset guidance, and the current or new guidance basically states that any enabling treatment that can be classified as a first definitive treatment can be classified as a first definitive treatment if it is clinically necessary to start the treatment. So there may be some scenarios where patients might not be ready for example, surgery because they need to lose a certain amount of weight, or we've had a few lung patients who their lung function isn't quite good enough to operate yet, and the doctors have said, let's trial 6 weeks, see where they're at, and then potentially we can start go down the avenue of surgery rather than other treatments. So the key thing with this is it says it's kind of subjective to the clinician. We're still trialing it and having a look to which patients count under this enabling treatment, because it does need to be clinically necessary to then start the treatment. But it's something that, from a lung perspective in particular, they started to pick out which patients were those borderline for surgery, borderline for another treatment. And so far for the 62-day treatment performance, we've seen a slight upward shift. And our data teams then looked back on whether, if we applied this to gynae last year, this was their forecast. So again, it's an estimate of the change we could have made to the 62-day targets. This is something that's very much in trial at the moment. You have to be very clear about the criteria as clinicians to what is clinically necessary, but there are patients that would fit into this criteria. And then, as I said, my data from a gynae perspective at the moment, the sample size is too small. So we don't have anything I can say we definitely know we're improving, for example, hospital data. So I just wanted to add in a quick bit of info from our previous, when we did the pilot for lung. So for lung cancer, when we started this just over 2 years ago, 65% of all those that were diagnosed in the year with lung cancer came to our prehab program. And when we compared those that came to prehab and those that didn't, and when we looked at the previous year's hospital data, we found that 84% of all bed days were spent by patients that didn't come to prehab, and that there was a 2-day difference in the average length of emergency bed day to those that came to prehab and those that didn't. And then when we looked into a potential cost benefit, when we add in the costs of running our service, we found that there was an estimated benefit of £135,998. Now, it's important to say that when we're looking at cost benefits with this sort of information, it's again not a hard science, because with the acute hospital, as we all know, if a bed's available, it will get filled by a patient in need. So it's not that we're necessarily freeing up bed space, we're potentially preventing an admission linked to cancer. So it's really tricky to show a true cost analysis. It's kind of an estimated, we know that there is a difference between those that come to prehab and those that don't. The other thing I will say with our prehab program is we also have people come back post-treatment. So we offer that follow-up prehab into rehab. It works really well, because patients that are waiting for surgery will see somebody who's post a hysterectomy and how well they're doing. And it almost helps break down some of that fear, some of those anxieties, and reassure them that if they try and look after themselves as best possible, it's just going to improve their outcomes as much as we can. From a feedback perspective, we always collect lots of feedback with prehab. These are just some examples. So we've had patients say, they've listened to my fears, I feel supported, lots of good advice and knowledge, feel informed. And what's really nice is a lot of these patients go on to build actual relationships. So they add each other on WhatsApp, and they all then join the same class in a follow-up class. And we've got quite a few patients that I still know now meet with each other regularly to support them through their treatments, because often these patients have quite a lot of different treatments, or fears of recurrence and all those sorts of things. And it's important to have that safety net where they feel that they can raise any concerns, and they just feel like they've got people who've been through the same journey as them. It is really important. I've talked a lot about prehab, but it is important to make sure you've got that follow-up care. If you're going to offer something beforehand, we need to offer something afterwards. It's really important from a gynae perspective, because we want to reduce the risk of, for example, hernias. We want to make sure they've got good abdominal stability. Pelvic floor, we want to try and improve their bladder or bowel function as much as possible. Continue with weight loss support, as often weight can be something that's a significant factor, a risk factor to a recurrence, for example. We want them to continue that journey. And specifically within our programme, our key focus with a lot of our gynae patients is weight loss. Within our local area, our weight loss service is quite limited. In fact, what we offer in the Acute Trust is about to stop as of next year in its main capacity, and it's going to be refunded out into the community. So we want to try and catch these patients as early as possible, be that support network, help them with the weight loss. So we have only just started working with the patients with our level 2 our band 4, but they're trained in level 2 diet and nutrition, has done some extra training with our dietitians to help with weight loss support, so that we can start to give them some information and advice on the general weight loss management. And it seems to be working well at the moment. It's something we're going to start to measure with those that are willing, to see if we can actually make a bigger impact on their weight loss journey. And then really just helping them with the abdominal stability and breathing type exercises will help with the stress and the anxiety of everything that they're going through. So overall then, for anyone that's looking at considering setting up prehab or rehab, the first thing I would say that we've learned is it's really important to know about the geographical area. So knowing where your patients live, but also where are they having their treatments? Are they going to multiple hospitals? Is there inequity between the different areas? Because I hate the idea that a patient, just because they live somewhere, doesn't get the same level of support as living elsewhere. It's also really important to look at what level of support they need. I would always recommend start with universal, because it's an easy win, giving them general advice so that those that are really keen can get the ball rolling, and then slowly adding in that targeted and specialist support. It is really important to note that the window of opportunity for prehab is quite narrow. It depends on different cancer sites and what your wait time is before they start treatment. For breast, for example, it could be 2 weeks you've got with them before they start their treatment. So the earlier we can get in, the earlier we can help. And particularly for gynae, the weight loss side of things, if they suddenly have been told they recommend to lose weight, they are in a moment of willingness to change. If we can catch them in that moment and create a lifestyle habit, habits take about 11, 12 weeks, we can then hopefully create a more long-term lifestyle change. I would really love there to be a more national pathway similar to that of stroke, pulmonary and cardiac. I hate the idea that cancer is quite far behind from the therapy perspective with physio, OT, dietitians, speech and language. I don't think we are as proactive as we could be compared to the other long-term health conditions, and I would like to see it more embedded into NICE and NHS England. And then making sure, if you are going to set anything up, it is having all the different multi-professionals on board, regularly meeting to make sure we are delivering something that is as gold standard as we can get it for our patients. So thank you very much for watching. I know I kind of blasted through it, but I was aware of the time limitations. If anyone does have any questions, I'm happy to hear them, but I'm sure it's a bit awkward in a big room.
We have actually got some roaming mics, so I'll just see if there are any questions for Sarah. Thank you, Sarah, that was brilliant.
It's all right.
Got a bit of feedback, sorry. Sorry, can we have the mic on? This one. Sorry.
Thank you for your talk. I think this piece of work cannot be emphasised with its importance for cancer patients. Coming from London, did you have any issues with patients that don't speak English as their first language?
Interestingly, yes and no. So we in Swindon, we also have quite a diverse population. So one of the first things was making sure any written content is translated, ready to go, and working with your comms team to get all of that translated, but particularly with because we do that education element as well, making sure the education is already written in various languages. So even if they're sat there listening, they have the paper information ready to hand. For us, I think there are challenges, absolutely. So we had a patient who had a very specific, basically, the written content wasn't something that our trust comms had done before, so they had to go and get someone external in to help. But with regards to the exercise groups and stuff, not really, because we can do the one-on-one, so we can take them aside and do things one-on-one if needed. That's why we've got the extra rehab assistants now coming in, because we've got a few people that need a little bit more one-on-one within the group setting. Hopefully that helps answer it.
That's great. Thank you so much for your time. Thank you.
That's all right. Thank you very much, guys. Bye.